Hello, ART practitioners. It's a pleasure to be here with you all today, albeit digitally and virtually from my spacious home office. This is where I find myself most days. As you may or may not know, Canada is in a pretty significant state of shutdown at the moment. Our province, Ontario, is in a state of emergency. So personal care, things like barbers, are not open. And most businesses, at least those that are not essential, are closed. So I find myself here with you. The purpose of me being here today is to give you a brief primer on the research and science behind ART. So we've got some pretty interesting research initiatives that are currently underway, and I'll touch base on those at the end of this presentation. But first, we want to really have a good understanding of how ART works and why ART works. This is important not only to be able to explain to our patients, but potential employers really need to know that there's something other than pinning and stretching, and that there's a vast amount of science that's actually gone into explaining why ART is so effective. So we begin with a look at some of the real groundbreaking papers that have been published over the last 2 decades with respect to myofascial and connective tissue injury. Probably the most important person to look at is Helen Langevin. So we know from her papers in 2005, 2006, and 2011 that when you take connective tissue, myofascial tissue, which is primarily what we're going to be working on with ART passes, not exclusively, of course, but if you take that and you stretch that tissue, what ends up happening is that the fibroblasts will immediately undergo a change. They increase their cross-sectional area, and we get instantaneous remodeling of actin and myosin. Now, the actin and myosin remodeling also takes place with formation of tiny little lamellipods, which are basically how the cell will increase in its cross-sectional area. Why? It does this because it's trying to regulate tensional homeostasis. So it's trying to avoid injury by mitigating any tension that you put into it. Now, we know from Langevin's 2011 paper that when this doesn't happen, we end up with an area that becomes very stiff and very easy to palpate as having an increased amount of tension. So something we are looking for as ART providers. Now, this is not a new concept. In fact, there are a handful of authors, a handful of papers that were published in the 1990s, which really set the tone for this, and they're landmark papers. And Helen Langevin's work really kind of expanded upon that. So we think of people like Ingber in 1997 and 2003, Chen and Ingber in 1999, and then Brown, both in 1996 and in 1998. Now, it's interesting to note that in her 2018 paper, Helen Langevin found that when you injure connective tissue, myofascial tissue, and especially when you immobilize it, so if you start to think, how often does someone have a shoulder injury and they choose to not move the shoulder because it's sore? Quite a bit. So when we have this, we note some really interesting findings. Obviously, movement restrictions, but we also get reduced fascial mobility, which will be increased tightness that we're going to be able to palpate. Now, Langevin in 2011 and 2018, as well as Bouffard in 2008, Corey in 2012, and Jiang in 2017, all noted that when you do the appropriate soft tissue therapy, like active release techniques, we can find reduced inflammation, decreased collagen deposition, and increased subcutaneous tissue mobility as a result. Which is exactly what we're looking for. So, especially that increased subcutaneous tissue mobility is key for people being allowed to excurd through their normal ranges of motion and perform their vocational or avocational tasks. But how? How do you transfer what goes on in your hands to what happens in the human body? The answer is mechanotransduction. So simply put, mechanotransduction is a conversion of the physical forces you would put into someone with your hands and the anatomical changes that occur as a result of those forces. Now, we know that cells communicate very efficiently between one another. So there are gap-based connexins that basically transmit information using either IP3, an inositol triphosphate, or calcium as the messenger, and they can shoot messages between cells incredibly quickly. But that's not really our concern here. Our major concern, or the star of the show, is something called an integrin. Now, we know from some in 2016 that an integrin is actually half intracellular and half extracellular. So what that means is that the integrin will sit basically in the cell membrane. Half of it is on the outside in the extracellular matrix, half is on the inside. What's the big deal? Well, anytime that you compress and take tension, creating some kind of distraction or some kind of fluid flow, you will actually move the integrin on the outside of the cell. But since it has an intracellular segment here, so it's kind of like a seesaw where the cell membrane is basically the axis of rotation, when I move the outside of this integrin, I'm also moving it inside the cell. Why does this matter? It matters because the cell is not just a bag of fluid. And so to this, we kind of owe a bit of homage to Dr. Levine, who is the gentleman who was a big proponent behind biotensegrity, biotensegrity being the extension of the Fuller principle of tensegrity. So basically, rather than a fluid-filled sac, a cell actually has a bunch of little micro-architectural tubules inside that give it a three-dimensional shape. Now, some of these microtubules actually go from the integrin to the cell nucleus, which is interesting. So what ends up happening is that when we do this on the outside of the cell and move the integrin on the outside of the cell, we're also moving it on the inside. Because a microtubule is attached to the integrin and then to the cell nucleus, we actually get a perturbation of the nucleus. In addition to that perturbation, there's also a biochemical pathway that's tripped, both of which end up with the exact same result, that being an alteration, excuse me, or an influence of gene expression. So what we see is mRNA being transcribed at the nuclear level, gets transported to the endoplasmic reticulum, where it gets translated into collagen. That collagen is then taken, pushed out into the extracellular matrix, and now we have a demonstrable anatomical change as a result of the forces that you put into the tissue using ART, which is pretty cool. So, in addition to this, what other research can we look at? Well, there's a great paper by Whiff in 2007 and also one by Porter in 2009, which talks about what happens to tissue when you either have damage, too much tension, or a drop in partial pressure of oxygen. So a tissue that's moving or being used a lot, so like a repetitive strain issue. So we know that any of these things are liberators of something called TGF beta, or transformative growth factor beta. TGF beta, along with PDGF, or platelet-derived growth factor, are two very important chemotaxins for bringing fibroblasts, but they're also the things that convert a regular fibroblast into a myofibroblast. You're probably already familiar with the concept of a myofibroblast. This was first brought to us, well, first really publicized to that extent by Dr. Robert Schleep in his landmark papers in 2004 and 2005. Who cares about a myofibroblast? We do, because myofibroblasts are capable of ridiculously long, sustained isometric contractions. And when they contract, they pull all the connective tissue around it, making it tight, which is something that we are going to be palpating for as ART therapists. Now, we know that from a work by Klinger in 2012 and Hines in 2012, that when you leave this connective tissue tension for long enough, the myofibrils of the muscle start to adapt and they actually get shorter in response. So now we're compounding this tension and this shortness. Now, Dr. Robert Schleep is the one who suggests that with something like active release technique, part of the immediate response that we get from performing a pass is actually a sort of stunting of the myofibroblast, so it's no longer contracting, and actually increases the amount of extensibility and decreases tension within the tissues. So we go back to Helen Langevin in her 2018 study. She noted that when she cut the TL fascia and then allowed it to heal and ultrasounded it, that on the side where the injury was, there was decreased fascial mobility, to be expected. She also noted when they ultrasounded the other side, there was decreased mobility there as well. Then when they applied therapy, stretching of the actual connective tissues, there was an increase in mobility, both on the side that was injured, but also on the side that was not injured. So we start to think there's something more at play here than just the sort of mechanics and mechanotransduction. And you're right, there is. The thing that's going to explain all these other changes is neurophysiology. Now, from an ART perspective, there are really three inputs that we have from a neurophysiological standpoint. So they can be broken down into peripheral, spinal, and supraspinal. And each of these has kind of their own flavor in terms of what they really influence. They're all very distinct and all quite powerful and effective. So let's look at each of those specifically. Now, from a peripheral standpoint, we know that if you get a musculoskeletal injury, you're going to induce an inflammatory response out in the periphery. That's going to initiate healing, but also the processing of pain. Now, inflammatory mediators and these nociceptors will respond and react to injury, but they will also positively respond to mechanotherapy like ART, which is super important for us. So a 2006 paper by Jan saw that there was a very significant decrease in serum cytokine levels in the group that received soft tissue therapy versus the control group. Likewise, Dengerhart in 2007 and McPartland in 2005 all noted a significant increase in beta endorphins, enkephalins, and serotonin in the group that got soft tissue therapy. Additionally, Smith in 94 and Field in 2002 noted that when there was an increase in substance P or an inflammatory response that was produced by exercise, that soft tissue therapy like ART is able to actually influence the inflammatory process, which is pretty cool. So all in all, pretty interesting effects that ART can have from a neurophysiological perspective out in the periphery. But it doesn't stop there because there are actually effects we have on a spinal level. What are they? Things like generalized hypoalgesia, so spread throughout the whole body. This comes to us from George in 2006, Mohammedian in 2004, and Vincenzio in 2001. Afferent discharge comes from the Coloca papers in 2000 and 2003. We've got motor neuron pool activity inhibition, so a decrease in kind of spasticity and excitability from Bulbulin in 2002 and Dishman in 2003, and also changes in muscle activity, most notably a decrease, again, in that sort of spasticity that we get from the Simons paper in 2000 and Herzog in 1999. Now, there's a really neat paper in 1996 by Straubeson and Lee, and they were looking at the deep crural fascia of the leg. And what they found was a really robust innervation of autonomic or sympathetic nerve fibers in the deep crural fascia. So now we really start to realize that there's a really heavy link between the autonomic system and fascial tone. And in fact, in a Basmagian paper in 1985, they noted that when a patient, one of the study participants, when they were in a sort of excited state, people that palpated them all said that they felt tighter. However, when they did EMG on those same patients or the same participants, there was actually no change. So there's an increase in fascial tone, and it's not due to EMG, it's due to the sympathetic nervous system, which is pretty neat. Now, one of the things, as you know, as ART providers, that we pay a lot of attention to is the concept of touch. And that's why we have people come back and recertify so they can hone their skills, they can practice what they've learned, they can get a little more tutelage, and they become more expert in performing ART. Why does it matter? It matters because precision matters and comfort matters. If you are not precise and you are carpet bombing an entire structure and you are over treating it, you are going to increase sympathetic tone. You do that, you're going to increase fascial tightness, the thing that you're actually trying to mitigate. Likewise, if you're very rough with your contact, lots of skin pull, very pointed with your contact, deeper than you need to be, once again, driving up sympathetic tone, which will drive up fascial tone, which we don't want because those are going to be counterproductive. Now, the last area, we've looked at peripheral, we've looked at spinal, is going to be supraspinal. And a lot of this research comes from rat studies. Particularly, there's a Melissa study in 2003. So they took rats, anesthetized them, and slid them into a functional MRI. So in this way, we could monitor the areas that you would assume that we would monitor for higher order processing of pain: periaqueductal gray, anterior cingulate cortex, frontal cortex, sensory motor cortex. Again, pretty standard fare there. So they get a baseline with the fMRI, pull the rat out, inject their little paw with capsaicin, and then put them back in. Immediately, you see boom, 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 increases in activity in all those areas involved in pain processing. Pull the rats out, perform some soft tissue therapy, and put them back in. And all of a sudden, those areas, boom, quiet down significantly. So, from all three vantage points, peripheral, spinal, and supraspinal, ART has a very significant effect. Now, looking at what the future looks like, a little uncertain at the moment, but we've got a couple of very interesting research initiatives and several papers that are currently in line waiting to get published. The two waiting to get published, one is a systematic review of active release techniques. As you're probably aware of, there are close to 50 papers that have been published on ART, which is very significant. And that body of work far exceeds any other soft tissue therapy system that's out there. So we've got that in the works, and there's also a paper on our ART corporate solutions data. So basically 4 years worth of ART corporate solutions data showing how effective it is at limiting the number of people who end up going to a workers' comp claim, which is great. In addition to that, we've got two trials that are currently underway. One is in the recruitment phase, and one which will begin recruitment hopefully in the summer, this summer, which is in Australia. So it's a joint project with CQU, and it's looking at changes to soft tissue extensibility with active release technique followed by, assessed by elastography. So basically, you get a sense of the tissue elasticity and extensibility, perform an ART pass, and then assess the extensibility with elastography afterwards. It builds on some research that's been done prior to this with massage therapy. So we're hoping to see that there is actually an increased amount of stick, if you will, or that the changes in extensibility last longer. So there will be sampling from the intervention time outwards for a couple minutes. Second study, which really kind of strikes to the heart of what we really need research for, is looking at ART for subacute and chronic lower extremity myofascial injuries. And that's going to be compared to a sham treatment. So it'll be blinded. And basically, the participants will go in and they will be randomized into either the control group or the ART group and will receive therapy. And then, of course, we'll track the results using things like numeric pain scale and different functional measures in terms of pain and function of the lower extremity. So very excited for those two, and they should contribute significantly to the existing body of work that ART already has. That's it for me. Thank you again for struggling through this, and hopefully one day we can do this in person. Stay safe.